everyone, and welcome to today's Capillary Parkinson's meeting. My name is Andrew Hodge. I'm currently serving as the Vice President of Outreach for CAPS. We wish everyone to know at this time we have decided to postpone the Fall Gala due to the current pandemic situation. We will send out more information as we finalize the details. We are also working on some additional fundraising efforts, and we'll let everyone know about those once the plans are finalized. Several of our support groups are meeting virtually. Should you or anyone you know be interested in attending a support group, then please call or send us an email and we'll connect you with the group. The CAPS contact information can be found on our website, capillaryparkinsons.org. The speaker today is Dr. Eric Cross, and the topic for today's presentation is the gut and Parkinson's. Dr. Cross is a neurologist with Seton Brain and Spine Institute, which is part of the Ascension Texas network. His areas of practice include general neurology, movement disorders, and Parkinson's. He has a special interest in spending time with his patients, continually focusing on improving their quality of life. He graduated with honors in 2014 from Nova Southeastern University. He completed his residency at St. Louis University of Medicine and his fellowship at the University of Texas HSC at Houston. Outside of the office, Dr. Cross enjoys traveling, sports, and spending time with his family. Thank you, Dr. Cross, for speaking today, and the floor is yours.
Okay, hi everybody. My name is Eric Kraus. I'm one of the movement disorder specialists with Ascension Seton here in Austin. I'm going to give a lecture today to all you guys about the gut and Parkinson's disease. And I just want to make sure that you don't lose anybody with this title because it actually is a pretty important topic. And so we'll go over how involved the gut really is with the evolution of Parkinson's disease. So hopefully you guys enjoy. All right, so I have no relevant financial disclosures, and I will be discussing some off-label techniques and treatment plans. So we'll talk about the anatomy and physiology. Hopefully it's not too boring and in-depth about both Parkinson's disease and the gut and the GI system in particular. And we'll talk about some theories on how these two interact and some of the theories on how we can kind of manage some of these symptoms. We'll go into associated symptoms, treatments and diets, and then some implications for the future. So first off, yes, your gut really does have a nervous system. It's kind of surprising. A lot of people don't realize this, but they call it the second brain, and they've said it contains over 100 million neurons, and this influences the muscles of the gut, which is called the smooth muscle. And so you can see over on the left a nice anatomical diagram of all these nerve endings that kind of innervate or activate the gut and make it move. And we'll go into some of those details. So the gut, or the nervous system of the gut, is called the enteric nervous system. That's just a fancy descriptor of it. And it's really interesting. It can operate independently of the brain and the spinal cord, so it can do its own functions, and it's mostly governed by what we call autonomic functions, or which is almost like automatic functions. So digestion, moving food through the gut, creating gastric juices, and things like that, which are essentially automatic, and they're controlled by a whole different nervous system set called the autonomic nervous system. It contains neurotransmitters, which are hormones of the brain, such as dopamine, which everyone knows about in Parkinson's. So there's about 50% of your total dopamine is actually in your gut. Serotonin, another very important neurotransmitter, which is involved in mood and things like that, in the central nervous system, is highly localized to the gut as well. And then acetylcholine. And then we talk about neurons, which are cells of the brain, are also embedded in the GI lining. And so here's a nice diagram of showing the autonomic nervous system and how extensive it is, going up to the nervous system and to the spinal cord, and then some of those higher level spinal functions can even go up to the brain as well. So here's a nice overview of the gastric anatomy. We have our esophagus, obviously, which feeds into the stomach. Then you have your portions of the small intestine, such as the duodenum, the jejunum, and the ileum. And we know that levodopa is particularly absorbed in the small intestines. And that's why it's really important that we talk about this, because that's exactly where your medicine ends up going. So a little bit of background on Parkinson's disease. Hopefully a lot of people know about this stuff, but going into the science of Parkinson's, It's defined by a loss of dopamine producing cells, which are mainly, again, we think about in the brain, but it also happens in the gut. And so we'll get into that. Dopamine is a neurotransmitter or neurohormone that goes throughout the body and mainly into the central nervous system to produce, action or movement, and kind of regulates how quickly and slowly you move, and also can end up causing the tremor, ironically. So you have slow movements and too many movements. We divide Parkinson's into the motor symptoms, which I talked about, the tremor, the slowness, the stiffness, and then also non-motor symptoms, which would include whole sorts of symptoms such as, constipation, depression, and we'll kind of get into some of those other symptoms. Alpha-synuclein is a fancy term for these proteins that are abnormally accumulated in Parkinson's, which end up forming these Lewy bodies. You can see this diagram showing these protein accumulations into the famed Lewy bodies, and then under the microscope you can see here. And these are also, seen in the gut well before you end up developing these central nervous system motor manifestations. So again, talking about the motor versus the non-motor signs, this is very important. We've come to realize that obviously the motor symptoms are very debilitating. Walking and falling, having slowness in your movements. You can see here this classic photo of somebody stooped with their posture, taking small steps with a resting tremor. You also get stiff movements and slow movements as a result of these motor symptoms, which are a manifestation of the central nervous system. Okay. Now, the non-motor features of Parkinson's disease includes a whole list of these things. And, some people think that some of these non-motor symptoms are actually more debilitating than the motor symptoms. For instance, dementia, which I'm sure you guys have heard much about, constipation, drooling, all these things, which we'll, again, go into. Now, the role of the gut in the Parkinson's disease is an interesting one. There's this famed term, the gut-brain axis, and we have an interplay of the vagus nerve, which acts as such as a highway from the GI system up to the brain. The vagus nerve controls a lot of those autonomic functions in the gut, and all those automatic functions in the gut, where they kind of produce the gastric juices or help moving the food through the gut. And that vagus nerve, we think, might help or might assist in the propagation of these alpha-synuclein Lewy bodies, which are pathognomonic for Parkinson's disease. So there's this theory that there's some sort of spread between the alpha-synuclein, which damages the dopamine cells, and it spreads via this vagus nerve up into the central nervous system. Now, we don't really know why this happens. Now, is it because of environmental factors? Is there a genetic component? Is there inflammation? All these things we think that probably all play a role. We don't really know exactly what the primary trigger to all this stuff is, but something around those lines of it, inflammation and all these things somehow trigger this reaction to where it travels up that vagus nerve into the brain. And that's the working hypothesis. But the truth is, we don't really know. Now, some things that we do know is that certain toxins and inflammation can cause the propagation of Parkinson's disease and even worsen Parkinson's disease. One thing that's been well studied is the environmental exposure hypothesis of pesticides. So, things like anything that a lot of these pesticides have been taken off the market, but if you've been exposed to a lot of these things, that is a possibility that it can worsen or even cause Parkinson's. Also, here's a photo of heroin, which has been shown to be a nice model for Parkinson's in San Francisco back in the day when they first discovered some of these harmful effects of, what environmental things can cause Parkinson's. Heroin was one of these things. And so that is a nice research model, which we've used in the past to say, okay, well, some of these aspects of heroin can actually cause Parkinson's, but and so we use these models as research tools. And so very interesting things. I don't know how often you run into this, but as a movement disorder specialist, I ask almost all my patients, hey, how's your sense of smell? And I don't ask that just for fun. We really ask that for more of a clue, like a diagnostic clue to say, oh, maybe this tremor is more of a Parkinson's tremor, because people with Parkinson's end up losing their sense of smell. And not everyone has this, but it's a very common complaint. And so a lot of people think that As this alpha-synuclein and disease travels up from the gut through the vagus nerve up into the midbrain or the beginnings of the lower part of the brain, that area, once it reached the central nervous system, can actually affect your smell. And so some of these things are what we call premotor symptoms. So it's a clue that, hey, your sense of smell started maybe 5 years ago, and now you've gotten the tremor. So it might be something, a premotor symptom. And that's why it's important that we talk about those things. Now, I've mentioned the vagus nerve and just a little background on what it does. I've kind of told you that helps with motility of the GI system and acid secretion and then emptying your bowels. Research suggests that, and here's kind of a nice slide on how this aggregated alpha-synuclein travels up that vagus nerve and probably ends up in the central nervous system via the vagus nerve. So that's the working hypothesis. It's based on Brack's hypothesis, which you can see here in this fancy slide where you have all these things working together: inflammation, you have inflammatory triggers that we don't really know of. Maybe it's the pesticides, maybe it's some of these genetic abnormalities, who knows? But we have all these working hypotheses to say, well, that's when your alpha synuclein becomes mutated essentially and then travels up that vagus nerve up into the brain. And so on the left diagram, you can see it marching in these stages of Brack's stages. And as it becomes more evident, you can see the center part of the brain is where your main part for motor movements are. And as it becomes more, infected with this alpha synuclein abnormality, that's when you start to develop the motor symptoms. But as it climbs up the lower part of the brain, that's when you start getting the smell loss, lack of poor sleep, maybe depression and things like that. And then eventually you might develop those motor symptoms. So a really interesting thought about why this might happen, or even how we can prevent this from happening, is, hey, the gut has a lot of bacteria too. It's not just nervous system, but we have a bunch of bugs living in our GI system. So upwards of 100 trillion bacteria, and we call this the microbiome, and it does play a key role in our immune system. And it clears out pathogens. You have humoral immunity to create antibodies and things like that. And so we have a symbiotic relationship with the gut and its microbiome, but also the loss of some of these bugs might predispose us to the evolution of Parkinson's disease. So we have a lot of people looking into that, and we'll kind of touch on that a little later and see if, are probiotics an option for people like us. So, well, the gut bacteria, we talked about this a little bit, so more of a, just to reiterate these things, but we've actually had studies that show that certain species of gut bacteria, like the Privotella species, which I have no idea what it is, but there's all these different bacteria types in the gut that we might see less of in Parkinson's disease. We haven't really worked out this theory, but it seems like this also may occur in the nasal mucosa, predisposing you to that smell loss. So that brings me to this theory of probiotics, which has some, interesting qualities to it, but it seems like it might not be all thought out yet. There's probably some truth into probiotics, but again, there's not great evidence to suggest that it really stops the progression of Parkinson's disease. But there is some evidence to suggest that it might modulate inflammation and oxidative stress by protecting the gut. And so we haven't really followed these patients long term, but under the microscope, it makes kind of sense. But again, we just don't have great data supporting this. So when people come to me and say, "Hey, doc, I've read somewhere online that probiotics might help my Parkinson's disease," I say that's great. It's worth a shot, but we don't have great data to suggest any of these things. But on the surface, it sounds like it might work. And there is some data also suggesting it might be helpful for constipation, which is very common in Parkinson's patients. Now, this is kind of a silly slide. If you think about a fecal transplant, ew, that sounds gross. But it's a very novel idea and a great idea, in my opinion. But we use a fecal transplant procedure for certain infections in the gut, where we say, hey, I'm going to take the healthy gut bacteria of a healthy patient, and I'm going to put it in a pill in a micro, kind of shave it down into a pill. And I'm going to give that to the patient who has a gut infection, like C. diff, which is something that we use to treat it with. And now the question arises, would this work for Parkinson's? Can we replace that unhealthy gut bacteria with someone's healthy gut bacteria? And so there are some studies that suggest that this might be a possibility, but again, this is ongoing. We haven't figured this out yet. There are trials ongoing. Nothing has been successful thus far. Nothing is definitive thus far, but there's hope on the horizon, and interesting hope, if you ask me. Okay, so what about preventative therapies? What if we just take out that highway that we're talking about, the vagus nerve that connects the gut to the central nervous system? What if we just chop it off? Do we really need that vagus nerve? Can we stop it before it actually propagates up to the brain? And they've actually looked at this. And in fact, it's data that they looked at retrospectively, meaning they looked back on people who had a vagotomy, which is eliminating that vagus nerve. And those people obviously had it for different reasons, but they looked at how likely were these people to end up having Parkinson's versus the general population. And overall, the data is mixed. There has been data to suggest that a partial vagotomy or a halfway, which you can kind of see here in this image, that they cut part of the vagus nerve, might have some benefit and might actually protect you from Parkinson's disease. But overall, that data is really kind of shaky, in my opinion. A complete vagotomy, however, did not protect against Parkinson's. So interesting idea, but in my opinion, it doesn't seem like it's holding much ground. And again, we just don't have those great studies where we look at people over time head to head by saying, well, let's watch you. Instead we look back at the data, which isn't great. Another interesting idea is the appendix. The appendix, ironically, just houses so much alpha synuclein. It's one of these places that has the normal alpha synuclein and not the Lewy bodies itself. And so people think that maybe that's part of the start of Parkinson's. Maybe it's the appendix that's the primary source of all this. And so they have looked at data retrospectively, again, where they look back at people and say, well, those people that got the appendix removed, are they more likely to develop Parkinson's over time? And again, that data is kind of shaky as well. It doesn't seem like taking the appendix out is going to prevent you from getting Parkinson's. So again, people are thinking outside the box, but the data is just not there. And the idea of the gut being the start of Parkinson's seems like a pretty firm hypothesis, but where it starts and how we prevent it from propagating is where we're kind of dropping the ball. Another interesting place is the tonsils, and the tonsils house a bunch of immune cells, so it's really kind of an interesting spot. It has a really big role in mucosal immunity. It protects the gut from being invaded by um, harmful bacteria. So we look at the tonsils and its direct correlation to the vagus nerve. And again, the data is unclear. We don't have great head-to-head trials where we take out tonsils and see how you do. We have to look back at this data and kind of, you know, uh, come back to conclusions to say, well, maybe that's protecting people. But again, it's really unclear. So here's a nice slide on some of these theories that we talked about, and how alpha-synuclein travels up that highway from the gut up to the brain. And it's just a nice little slide on the whole totality of what we've talked about so far. Now let's talk about symptoms of the GI system in correlation to Parkinson's disease. So as we start with the upper GI tract with the mouth and then moving into the esophagus and down into the stomach, you can see these problems. And you basically say any part of that GI system, it looks like it can go wrong in Parkinson's, basically. So with the mouth, you can see excessive drooling or sialorrhea, which is very common in Parkinson's patients. That might be a manifestation of forgetting to swallow. Those muscles are slower than they used to be. Also, you can have dysphagia, which is trouble swallowing, which it happens later in the disease. All these things usually happen later in the disease, but again, it can happen earlier. In the stomach, we have delayed emptying of the gastric juices and some of the things that sit in your stomach. In fact, they've done some interesting studies where they put a video camera down into the gut and people with Parkinson's, and you can actually see some of these pills that people take are just sitting there. They haven't moved. And it goes to show you how interesting and how the absorption works of these medicines and how unpredictable they can be, especially if you're not moving those contexts of the gastric of your GI system. And then obviously constipation, and heaven forbid we had any kind of perforation of the gut, but very uncommon. So talking about drooling, we call this also sialorrhea. It's the fancy word for drooling, but basically this is due to a reduced swallowing frequency, which allows the saliva to pool and accumulate in your mouth. And this can cause a bunch of issues. Not only is it difficult to understand you, but a lot of people end up saying, doc, I got to carry around a rag all the time. I got to carry around that rag to dab on my mouth and really relieve the drooling. And that can be troublesome for people. In fact, it even causes some people to have difficulty swallowing. And so you might notice this more so in the off state, quote unquote, the off state, meaning that you're not feeling the medicine take effect. And so that's why we treat people with dopamine drugs like levodopa. And so sometimes this improves with that. Another great treatment option for drooling is actually botulinum toxin or Botox that can be injected into the salivary glands and can help people essentially not produce as much salivation and swallow better. So that moves into swallowing. This is something that is really important to notice. If you notice that you're choking or coughing after eating solids or liquids, that's a red flag, and that's something that really needs to come to the attention of the provider. So do not take this lightly, because swallowing issues can obviously kill you. If it goes down the wrong pipe, you can aspirate and even cause a pneumonia, and then you got bigger problems. So that's what we call silent aspiration. It's really important to make sure you're on top of these symptoms. In fact, if you do have some of this, you need to probably see a speech therapist or even get a swallow evaluation with a barium x-ray if needed. So don't be afraid to bring this up. And it can improve with speech therapy, which is really important. Constipation is probably the most common GI symptom that you see with Parkinson's. I'm sure everyone who's listening to this can probably attest to that. About 90% of PD patients or Parkinson's patients can report constipation at some point. It's one of these symptoms that we call a premotor symptom, meaning it comes before you end up getting the tremor or slowness, those motor symptoms. This can happen even 20 years before you notice that you have even Parkinson's. So I get a common complaint is, hey doc, yeah, I've had constipation for probably a decade. And that's not uncommon. And this is due to slow emptying of the stomach, which is also called gastroparesis. And this is also a symptom which you can see when you take medicines, which we talked about. And, that's why it's important that we get a handle on these things to fix, so your medicines can be absorbed and you can be treated appropriately. So again, why is controlling constipation important? We talked about med absorption. It's very important to get those meds in and have a predictable nature to the treatment quality that we have. Also, constipation can cause pain. It's very uncomfortable if you've been constipated for days on end. And then heaven forbid, it turns into a bowel rupture, which that's more to scare people that we shouldn't take this lightly. And that's very rare to happen. So treatment for constipation, I tell all my patients these lists of things to do. These are natural things to do, which everyone should be doing who has Parkinson's. Obviously, increasing your fiber is important. This includes fruits, vegetables, grains. Exercising can move the bowels, so I highly recommend that. Not only is exercise good for Parkinson's, but it's good for your GI system. Maintaining a proper hydration, which I'm sure nobody does, but make sure you're drinking enough water. That can also move things along. Eat enough. This one's actually really important. Some people say they have constipation, but they don't even eat. So it's like, no duh, you have constipation because there's nothing moving the bowels and nothing filling the bowels. So when I say eat enough, if you've even eaten, 3 meals and you're eating pretty good, sometimes even chopping those meals up into 5 times a day, the same amount, obviously, you don't want to gain weight, but chopping those meals up into more frequent meals can actually move the bowels too. And I included a picture here. Again, I don't have any financial disclosures with this, but Squatty Potty is something you can get online, on Amazon, anywhere. And it's basically what we call a stool for your stool. And so you elevate your feet, elevate your legs, and that straightens your rectum, and hopefully makes going to the bathroom a lot easier. So very easy. It's cheap. Consider it. I know it's silly, but. And then reevaluate medications. If you're on narcotics or things that slow the bowels, It'd be silly to not address those things first and then add another medicine for constipation. So just to go through the fibers, obviously we talked about a little this. Fruits include bananas, kiwis, apples, pears. These are good things. Prune juice is something I highly recommend when you have constipation. Certain vegetables with the skin is obviously better. Whole grains, bran products, nuts, beans, and peas. These are all really good to increase your fiber and help with constipation. So treating constipation is a tricky thing, especially with medicines. A lot of docs don't really understand the process of constipation and how to attack that. Are you producing enough stool, or is it small stool? Are you not even moving the bowels? Do we need to stimulate that? So based on what you kind of say to the physician, we should probably make decisions based off those symptoms. But here's some medicines that I always suggest to people. My personal favorite is Miralax. It seems to have the best data behind it. But again, a lot of these medicines work for different people. So, just move on to the next medicine if you feel like one doesn't work. So, and a lot of these are over the counter. So, highly recommend. Don't let, if you go with 2 days without moving a bowel, you really need to consider taking some of these things if you haven't tried the lifestyle changes that were suggested. So gastroparesis, this is what we talked about earlier, where that gastric motility or moving things through the bowels is just not moving as it should. It's just kind of getting stuck. And that's where the vagus nerve plays a big role, and it helps move those things along. And again, it affects the way your pills are absorbed and can cause things like motor fluctuations where, you have unpredictable on and off states with your medicines and the disease. So for instance, if I took my 8 a.m. medicine and I might not feel it until 10 a.m. because you're just not moving it through, it's not getting absorbed. So as a physician, we really kind of bang our heads against the wall when people are constipated and not moving the bowels, because man, we want to get that med in. We want to predict exactly when it's going to work so we can make treatment changes based off that. Symptoms of gastroparesis include nausea, vomiting, getting full early, and then abdominal pain and things like that. This occurs in almost every patient with Parkinson's, but you might not even know. And it's most prominent in some of these atypical syndromes like multiple system atrophy, which you don't need to know about. But if you did have certain atypical syndromes where they're more severe disease, you might want to be cautious of some of these symptoms and bring them up to your doctor. Now, a question I get a lot is I'll start people on a medicine for Parkinson's, like, for instance, levodopa, which is probably the most common medicine. And it is listed in the side effects, probably for almost all these medicines, that it can cause constipation. Now, that is certainly true, okay? But I find it very, very, very rare that that is the case. I personally think that the Parkinson's is the main offender for constipation, but I just want you to be aware that it could cause that, although it's very unlikely. Okay, so when I get that question from the patient, hey doc, I started that medicine. I think I'm more constipated than I was before. I say, make sure you're doing these lifestyle changes. Let's give it a little time so you can get used to it and see if that goes away. And usually it does. Metoclopramide, or Reglan, is a medicine specifically used to move the bowels, especially in people who have diabetes. The problem with this drug, and it's a great drug, but the problem is that it blocks your dopamine. And so this can make your Parkinson's worse. So this is more of a PSA for all the Parkies out there, that if you are given this drug, metoclopramide or Reglan, that could make your Parkinson's worse. So just be aware that's one of those special medicines that you just need to, keep a radar out for. And so, if we need to use it, it's not a problem, but it might make some of your tremor and stiffness worse. Okay, so moving on down the GI system is hypersalivation or drooling, which we talked about earlier, obviously, but the medications we can talk about include, Robenol, or things that dry you out. But then we talked about Botox a little bit earlier, so I won't belabor that. Probably the most common question in this GI system realm and Parkinson's disease, almost in general, is, hey doc, what's the best diet? I've heard this, I've heard that, I've heard the keto diet, and the short answer to this whole question is, man, we just don't know. So if you hear anyone that swears by a certain diet, there is absolutely no data to support one way or the other. Okay, so let's go one by one. The probiotics we talked about a little bit, but there's some mixed data. It sounds like it might help with constipation, but again, there's some data that suggests that maybe it doesn't. But for the most part, it seems like if it doesn't hurt, then it's fine, you know. But I wouldn't live and die by this probiotic theory. But there is some data that suggests that it might help. Now, the ketogenic diet, again, it seems like a great idea. A lot of people say that protein may interact with the way you take levodopa. In fact, that's partly true. So, what I tell patients is that you take the levodopa 30 minutes before a big meal or an hour after a big meal, or essentially without protein. Just make sure you're taking it with crackers, fruit, or whatever. Now, the idea behind the ketogenic diet is, we're saying we're taking away carbs, and it seems like that there is some benefit to it. Now, the benefit that we've seen in studies is the fact that it improves a lot of your non-motor symptoms. It might improve depression. It might improve um, constipation a little bit. It might improve anxiety. Things that help your quality of life. The ketogenic diet might improve, but the biggest caution I give patients who are on the keto diet is the fact that if you have Parkinson's, for the most part, people don't really gain weight. Usually, people kind of stay the same weight or even lose weight. And so, if you're having trouble keeping weight, or you're having trouble swallowing, or you're low weight to begin with, I do not recommend the ketogenic diet. However, there are some benefits, like I discussed earlier. So I'm not saying I'm writing it off completely, but you just need to be mindful and probably discuss it with your doctor before starting on one of those diets. Now, the Mediterranean diet is a very interesting theory. It's probably my favorite diet out of all of them if we had to choose one. And you can always Google what the Mediterranean diet is, but it's essentially lentils, vegetables, greens, fish, olive oil based diet. And the idea is that they've actually shown that people who have been on the Mediterranean diet might have a less likelihood of developing Parkinson's. And that's the theory that's been worked along. And, there is some minor truth to that. It seems like what they've studied is that people who are on the Mediterranean diet might have less of the premotor symptoms and some of those things that turn into Parkinson's. And so they assume that they might have less risk of Parkinson's. But to be honest, the data again is not that clear. But it's one of the healthiest diets for diabetes, for high blood pressure. And so if you're going to choose one of these diets, it's going to help all these other things, like what we talked about, diabetes and hypertension or high blood pressure. And those things can actually accelerate Parkinson's. If you have diabetes and Parkinson's, you're going to be worse than the people that don't. And so that's why the Mediterranean diet might be a good one for you. Now, coffee is a great one. There's been several replicated studies, again, longitudinal, where they look back on people who were coffee drinkers versus not coffee drinkers. And the people who were coffee drinkers are less likely to develop Parkinson's. So, if you already have Parkinson's, there's no reason to think that coffee is going to prevent you from having it anymore. But it might have some data to suggest that if you were a coffee drinker in the past, you might have a less likelihood of developing Parkinson's. So, again, don't go out drinking a billion cups of coffee if you already have Parkinson's. It's not going to stop the progression from what we have understood. So going into the ketogenic diet, I want to discuss an 8-week pilot study that they used the ketogenic diet, and it showed improvement, like I said, in those non-motor symptoms. But the problem was it's a small duration, under a year, and a small sample size, which kind of limits the data value. So again, like I said, one must be careful of weight loss, especially if you're in the later stages of Parkinson's. So make sure you discuss this with your doctor before going full keto. Mediterranean diet, you can see on the right some of those foods we were talking about and what's involved in that. And again, we talked about the lower probability of prodromal PD, so the possibility of developing these symptoms that you get, like constipation, prior to Parkinson's, might be less. And so we might think that there's a correlation to a less development or less likelihood of development of Parkinson's. But again, this data is very shaky. Um, but it can lower your cognitive impairment. We've kind of had good studies suggesting that you have a less likelihood of developing a neurocognitive disorder like Alzheimer's or Parkinson's disease dementia if you do adhere to the Mediterranean diet. So that's why, this is such a, if I had to pick one, this is just such a great diet. It helps with all aspects of life. Other foods that, again, small studies, but things that I at least throw out there that have been shown to reduce PD progression include fresh vegetables, fresh food, fruit, again, fresh things, non-fried fish, olive oil, and some of these fresh herbs and spices. Again, that sounds eerily similar to the Mediterranean diet. Foods associated with more of a rapid progression include canned fruits and vegetables, soda, fried foods, ice cream, yogurt, and cheese. But please do not take this to heart. These are very small studies and very inadequate studies, but have shown some possibility of these links. Coenzyme Q10 and fish oil have been shown to have a reduced PD progression in some studies, but again, these are small and limited. We talked about coffee. These people are less likely to become Parkinsonian over time, but again, this is the caffeinated coffee. You can't have decaf. And there's a theory that some of these fatty acids actually contribute to a protective role. And so there's this whole field of the fatty acid production in Parkinson's is really interesting, actually. And it's ongoing research, but a lot of mice studies, not many human studies with that. Overall, the best thing you can do if you have Parkinson's is exercise. And I cannot stress this enough. Maintaining a healthy lifestyle by cardio, getting your heart rate up is essentially the closest thing we have to a cure. We've actually studied in mice that those mice that were exercising more with Parkinson's compared to the ones that don't exercise, those mice actually can regrow those dead neurons or dead cells in Parkinson's. So I mean, it's essentially a cure, and so I can't stress enough the exercise part. We talked about high blood pressure and diabetes. This can correlate with worsening Parkinson's symptoms. So as long as you maintain healthy lifestyle to control those factors, I'd highly suggest that as well. So we talked about this a little bit, but what's the deal with protein? My doc says I can't take protein with my meds and this and that. And, in all honesty, if it creates such a burden on your lifestyle, then don't worry about this whole deal with protein. Take your medicine as convenient for you. It does not matter. Okay. But for the most effective absorption for the levodopa, we want you to take it, like I said, 30 minutes before or 60 minutes after a big meal or without protein. And that's because the levodopa kind of battles with the protein when it gets absorbed. And sometimes that protein can kind of push it out where it gets absorbed and it has a delayed absorption, so you don't get that kick of the medicine. All right. And some, if you do get some dyskinesias, which means that you're moving too much and the medicine's too strong, sometimes you can actually take more protein to kind of help with those excessive movements to help bind against the levodopa or dopamine. So this is just showing how levodopa ends up coming into the gut and how it works. This is a very detailed slide as to how this works, and you don't really need to know these things. This is more of an academic slide. So again, I'm not, I don't have any financial disclosures. I don't work with any companies, but this is a nice novel therapy that we've started to use for our Parkinson's patients. It's called the Duopa pump. Some patients who are listening to this might have this, in fact. The idea is that this is a infusion pump that is directly fed into your small intestines, into the jejunum, and that's where levodopa is absorbed. And so you're bypassing the whole oropharyngeal pathway where you eat and drink, and you're bypassing the stomach essentially and putting that tube right where the small intestine is. And that will deliver the levodopa right to where it needs to be absorbed. And so the idea is that it's kind of like this port where you connect the tubing to the small intestines, and then you just inject the levodopa that way. So you can see here in this cartoon, this guy's wearing the pump here, and it's attached to your torso. And essentially, you just put a new cassette in of levodopa every day, and just don't touch anything. It just constantly infuses. And so the whole point is that you have a steady stream of medicine throughout the day, and you don't have dips or troughs where you get less medicine. And so when we talk about this, again, this is something that's for more advanced patients. This is not something we start out to do, and this is something you have to discuss with your doctor to see if you're a candidate. So implications. Now we talk about things that um, how how do we progress from here? What are some thoughts that we can do to maybe stop the disease from the GI system from spreading? And so what we say here is the vagus nerve appears to be a route for the propagation of disease, but it doesn't not necessarily mean the GI system is the site of disease initiation. So we're not quite sure really, but the theory is that it might be. So, with all this being said, I think what's really important is that we kind of make sure that we don't neglect the GI system overall. And what we think we know, we don't really know. And so when someone says that they recommend this diet, this supplement, this novel treatment that you can only get at this GNC or this nutritional shop across town, in all reality, we don't have great trials supporting this data. So if somebody tells you they swear by the ketogenic diet, there's just not enough data to suggest that that's a great diet. Maybe it is, but for the most part, the data is not there. Same thing goes with, a lot of these supplements like coenzyme Q10. We just don't have great data. But I know that's not a great thing to hear about all. What did we listen to? We come back to this thought of, well, we don't have the great data, but my job is to present you with the data and for you to make that decision, discuss with your doctor so they can make a treatment plan. And so that's hopefully what we sought out to do here, and hopefully we accomplished that. Just so you know, I practice over with the Ascension Seton Healthcare. I have two offices, one south of Austin in Buda, and then one downtown on 38th Street near the main hospital. And I'm always accepting new patients, so feel free to call us up if you'd like a new movement disorder doc, or if you need a movement disorder doctor. We're more than happy to take care of you over there. I also teach over at the Dell Medical School, so if you don't have insurance or you're MAP patient, you're always welcome to enroll in our clinic over there at the Dell Seton Medical Center with students and residents. So, and I also give lectures over there, and sometimes we have symposiums and things like that, which I highly recommend for the Parkinson's patients to get involved with, okay? All right, I appreciate all your time, and hopefully this was helpful. This is my dog, and we both thank you for this. And I know this is a strange time with coronavirus, and we have to do it this way. And I'd love to meet everyone in person and take questions, but unfortunately, this is how we have to do things, and for the near future. But if you do have any questions or anything like that, feel free to reach out through the CAPS organization. We'll try to answer that. All right, thank you.